is another cultural difference. I mean, dental cultural difference is that we have this perception of American dentists that you guys are, no offense, you guys are really aggressive, like treatment planners. Like you guys are like, you got like two hand pieces with these big fat burrs and you're ready to just cut crowns and everything. Hello, Protrusive. I'm Jazz Galati and welcome to this Interference Cast, all about the differences between UK and US dentistry. It's quite a light-hearted interference cast for you today with someone very special. Her name is Dr. Bette Robin, and she's the host of Dentistry Rising Podcast. And it's from podcasting and her being a dentist, actually doesn't practice dentistry anymore, which is actually interesting, so we'll discuss that in a moment. But her also being a podcaster in the dental niche, we sort of connected on this podcasting platform. We joined this weekly mastermind all about communities and online courses, and we were both part of that. And what are the odds that two dentists who podcast, who are also interested in running successful online courses, were meeting together? So that's what the story of how I got to meet Dr. Bette Robin, and then I got to listen to her podcast, and it's really great. I really like her voice, actually. So we had a very light-hearted discussion about the differences, the cultural differences in USA versus UK as a dentist. What are the earnings like? What are the biggest barriers? Like, one shocking thing for me was the level of debt that US graduates can land themselves in, but also she, understandably, was quite shocked to learn about how the national health system works here in the UK. So I hope it makes a very interesting sort of fly on the wall sort of listenership for you guys. Let's roll to the main interview and I'll catch you in the outro.
Well, I'm here on the Dentistry Rising Podcast today with Jazz Galati, who's a dentist in England. And Jazz and I met on an online study club on how to do online classes. And I was just absolutely thrilled that in this small little study group, another dentist joined. So what part of England are you from, Jazz?
Hey, Bette, thanks so much for being on. I'm enjoying doing this sort of joint thing with you. And like you said, you mentioned, what are the odds of two dentists in this very small little micro niche finding each other? So that's been fun in the last, I guess, 3 or 4 months connecting with you in that. I'm based in London and Reading. So it's a place called Reading, but I guess most of your listeners will obviously know of London in England, and that's where I practice as an associate. And I also have my own podcast, the Protrusive Dental Podcast. Obviously, this is going on both of our podcasts. So both listeners will hear a little bit of an interesting story between us and also how things are in the US and how things are in the UK in terms of dentistry, because I think there's very contrasting working patterns, I think.
Well, thank you so much for doing this because, yeah, I think it's going to be really interesting. I don't know a whole lot about how dentists practice in England, so I'm really excited to hear what you have to say. So can we start with, I think in England that you go right from high school into to dental school, basically, where you do your basic sciences, where we do them in college, and you go right in dentistry. So how do you become a dentist in England? You
know what? I didn't even think about where to start, and I think you're so right. Let's start there because there is already a big difference there. Because as far as I know, in the US, it's like dentistry is a postgraduate degree, right? Like you already have like they've done one thing already. So here it's like you're 18, and then you're pretty much in dental school, and then at 23 you qualify, which for you guys probably sounds like, whoa, that is way too young, right?
Well, I mean, not really. If you're focusing on, because like my dental school was 3.5 years. So you've got 5 whole years to get your basic sciences in, which I did in college before I did go to the graduate school, which is dental school.
Okay, that makes sense. I didn't know that.
Still a little young for us. Let's see. So you graduate from college 22 here in general, and then 25, 26 out of dental school.
Yeah, so we're about on average 3 to 4 years younger when we qualify. So I guess that's the first big difference.
And what does qualify mean?
Qualify means you get your bachelor in dental surgery, your BDS. You guys call it like DDS or DMD, that kind of stuff, right? So yeah, right. Essentially what I mean.
Interesting. And then from there, you go mostly into independent practice or mostly into groups, or what's your career path from there?
Most people, or 99% of the dentists, will do a training year. So it's called like dental foundation year. So it's like a year which bridges the gap from being a student into being an independent practitioner. And it's pretty much publicly funded. So we have the NHS here, which is a national health system. And we can go into that. I don't want to go too into that because it's quite a controversial area. But of course, I also want to learn about you guys and the insurance system, because we have some perceptions of the insurance system being maybe quite similar to what we have with the national health system. So basically, we have the national health system here. and we do this one training year treating patients under this sort of public health dentistry. And just to give you like the most shocking example of one of the issues with dentistry in the UK and the national health system is like the NHS is great for like the other week I dislocated my shoulder. Right, half an hour, I turn up the hospital, accident emergencies, we call it A&E, you guys call it ER. Fixed up my shoulder, I was never presented a bill. There was no insurance to contact. Like we don't pay for healthcare here, right? So it's just taxes pay for that. So everyone can get free access to healthcare. So that's the medical side. But in the NHS dental side, you pay a little bit, but a complete fraction compared to private dental care. But here's the downside, Betty, right? If I'm a patient, okay, if you're a patient, Betty, and you come to me and I'm performing NHS dentistry, and if you need one restoration, or you need 10 restorations, you pay the same fee. And the dentist gets the same fee. So sometimes, and that fee is pretty much, let's say, 40, I'll make it US dollars, 42 US dollars, okay? So whether I do one restoration or I do 3 root canals, 5 restorations, I get 42 US dollars. So sometimes my hourly rate is like, I might as well just work at McDonald's.
Yeah, it sounds like it. You have no incentive to diagnose then.
That's the thing. So the way we're going now, so it used to be fee per item, right? And then to make money, dentists would be on the other side of that. So be like over-diagnosing maybe, right? The trends. And now everyone's like, well, I think, it will remineralize and it's okay. So, but the perception I have, Betty, of insurance-based system you have is kind of similar. Like apparently insurances are very particular and they're peanuts. Is that the way it is?
Well, not really. I think you're kind of comparing it to like an HMO plan, a health maintenance organization plan, where it's kind of the same thing. There's no incentive to diagnose, but the dentist gets a certain amount per month, per head, since it's a capitated plan, whether or not the patient comes in. So it's really not necessarily in the dentist's best interest to have a patient come in and utilize their resources. So that would be comparable, I think, to an HMO, what you're describing, but not comparable to preferred provider organizations, PPOs, and private practice, where you definitely get paid for what you do.
What percentage of practices are fully private?
Well, I'm not an insurance expert, but I would guess in fully private, I'm going to call PPO and all cash, because the fully private, just cash, probably less than 5%. I mean, very small. But PPO, I guess 60 to 70% are PPO. So they are getting paid for what they do. And then we have, as you say, the other incentive, well, to diagnose too much and to do too much work, as compared to the HMO, which has a disincentive for doing too much work, like what you're describing. So, but that's not the norm. The HMO is not the norm, even though it's certainly growing without a doubt.
Well, in the UK, believe it or not, a lot of practices are fully private because it's either your NHS and then you do some private on the side. And the way you decide what you offer the patient is, if it's something they need, you give it on the national health system. If it's something they want, then you can do it privately. But here's where the lines get a little bit blurred, right? Is whereby, like crowns, right? Like you say to the patient, oh, I can only do a metal crown. And they're like, oh, but I want a white one. Oh, you want a white one? Oh, in which case you have to pay privately. So we call this mixed practice. So this is not how we are taught to be dentists, right? These are the conversations we don't want to have as dentists. So this is the biggest downfall as a nation we have. And because the prices are so low, I'm talking, like I said, rock bottom low for national health system dentistry, acts as an anchor for the private sector and brings everything down. So, it's difficult to justify true high fees because everyone, the Joe public thinks that, oh, but I can get 5 fillings for, $80, and you're saying one filling privately is, $700 or whatever. So it's just a massive contrast.
And we get into that a little bit with Denti-Cal or Denti-Care, as it's called in other states, where it's funded based on income. So if you have a low income, you would qualify for Denti-Cal or Medi-Cal and we get into that kind of thing. What do you want? With Denti-Cal, you get a silver crown. If you want to pay $500, $700, whatever extra, you can have a white crown. So we get into that as well with Denti-Cal as well as with HMOs. So what do you think the average crown fee is in England? What would you say? Okay,
that's a great question. And I would say, so if you are doing a crown for a patient who's getting national health service dentistry, so NHS practice, the patient would pay around about, and I'll convert to US dollars, the patient would pay around about $400 US.
Low, really low.
Extreme, yeah, good. So extremely low. Whereas
more in the terms of our Medi-Cal or Denti-Cal.
Yeah. But that's like, you could be earning very well in the UK and you can see an NHS dentist and they would charge you $400. But what makes it worse, Betty, is remember, like, that includes everything. That includes the crown, that includes the core, that includes the root canal, believe it or not, okay? And if they need 3 more restorations, technically, if you can do it like properly and play ball, you have to do it under that fee. That $400 covers everything, which is the problem. Now, I'm a private dentist, so my crown fee is £950, which is around about $1,600, well, maybe less, $1,500 US. Is that more comparable to what it should be?
Yes, for sure. Yes. I think most dentists here are probably definitely over 1,000, and the really, really good ones would be even over 2,000 or 2,500, 3,000. I mean, but I think most people in the $1,500 range is, really comparable. So this NHS, is that required? Is it like an internship? You have to do this 1 year out of school?
You kind of do. Like, you could go private, but who's going to hire you, right? Like, who's going to take a risk on, a brand new grad? So that's why I said the 1% it might happen, but 99% you do it. But you know what, Betty, the good thing is that this is like your training ground, right? You actually get so much experience because now we can talk about appointment times, because the average checkup time for NHS dentists or a dentist who performs an NHS contract will be like 10 minutes or 15 minutes. Whereas I'm privately, a new patient, I would see 40 minutes to an hour. I just can't operate at like a hamster wheel. Like, you're constantly just in and out patients. But we can talk about this big difference now, I guess, whereas we are seeing one patient at a time, right? So one patient gets 15 minutes in the diary. So we see 4 patients an hour, let's say, for checkups, and maybe that's how the average NHS dentist is. Sometimes you're seeing like kids 5 minutes, and you're just burning through them all. So in a day, dentists might see like 60, 70 patients, which I think is crazy. And that's why I couldn't do it. And I left the National Health Service. I'm fully private. But you guys, from my understanding, is most of you guys are just hopping from surgery to surgery, kind of doing the same thing. I mean, explain that to me.
Not really. I think the higher end dentists do see one patient at a time. The higher fee, operate just the way you're operating. I wouldn't say that's the norm. People do jump from operatory to operatory, but usually only 2 operatories where they're getting somebody numb and then they're going back and maybe finishing a prep, that kind of thing, and then coming in and working with the next patient. But at the lower levels, the HMO and the Denti-Cal, that kind of level, absolutely. And like you say, burning through the kids, where you have a whole line of them, and since we can delegate so much of it to auxiliaries, so burning through the kids and even the adults at the very lower end, same thing.
But Betty, it seems so strange to me, the thought of the patients just sat there, with the prep done, and they're waiting for the next stage. And I guess they're all used to it. I'm guess they're used to this way of practice because, how do you feel that awkward sort of silence, awkward pause, awkward gap? I just can't understand it.
Well, I think at the lowest level, they expect it. They're paying nothing and they know that's what they're going to get, and they're going to sit there and be on their phone or that kind of thing. But at the higher level where you are jumping a little bit, most doctors leave an assistant in the room with the person to chit-chat the whole time or do impressions or, kind of waste time in a lot of ways. But a lot of patients come self-entertained with their phones now, and there's the TV and all kinds of other entertainment options. But I would say the norm is to work with 2 ops. On most practices, a dentist is working in 2 operatories all the time, sometimes 3.
Okay, wow. Now, most of us is 99%. We're just working in 1 operatory, and that's it. One question I had, Betty, just thought of is average income levels, because here in the UK, we think like we all want to go to the US and practice because we feel like you guys have a huge, much bigger earning power. And I sometimes think the reason why our BDS, our dental qualification, is not valid in the US is because the US dental boards kind of know that if you open the doors to UK dentists, we'd all go there in a heartbeat. So that's my sort of rationale.
Interesting. So how much do you guys make a year on average?
Okay. On average, now this is according to accountant figures. So I've actually looked at the national dental accountants figures, and the latest figures suggest £68,000 a year. Okay, now obviously these averages are based on means and not medians, and it probably involves lots of part-time dentists, maybe mother of two who works 2 or 3 days a week. So the figures are a little bit skewed, but let's go with it. So it's £68,000. I think that's around about $100,000 I'd say, but that's obviously gross before tax.
And what's that comparable to other jobs?
Pretty good. Like the average income in the UK is £27,000. So £27,000 is the average full-time income,
Okay.
And then the dentist will get 68. So tell me, what's it like in the US?
I'm not really involved in organized dentistry so much, so I don't know if I can give you exact figures, but I think it's about 140 to 150,000 average for a general dentist. Specialists probably double that on most specialties are over 300,000. And certainly a lot of private dentists doing 300, 400 plus, that really have it dialed in and, high fees and are sitting with the patient and selling treatment and that kind of thing. So you're lower, but I don't know how that's comparable to cost of living. I mean, obviously there's a lot of other factors in there, but it sounds like we're quite a bit higher. Yes.
Which is why I think you guys have closed the door to us, you see, because we don't want to leave this contractual system that we have with public funded dentistry, and we probably all want to go to America. Now, I know some people who have left the UK for the US and done the additional 3 or 4 years or whatever, and spent a significant amount of investment to retrain and practice there. And they've all been pretty happy from it. They're happily practicing in the US now. And it's a big jump to make, 5 years in dental school in the UK. Then to go to US and do it all over again, it's a big step.
Yeah, it's a huge jump. I don't know if it's worth that, but who knows? Maybe it is. But yeah, sounds like we're making more money per se. What's the ratio of women to men?
Okay, so traditionally it was very much male oriented. So when I look at the photos from like dental school, 60s, 70s kind of thing, male. But nowadays, let's talk about today, it's about 62% intake females, and then about 38-40% male.
Oh, wow. We have very similar. We have probably 50-50 going into dental school right now. But I think nationwide, it's probably 20% or even less female still. When you factor in all the 60, 70-year-old dentists and all that, it's still overwhelmingly male, which is going to change in a few years. Yeah. So very interesting. Well, I'd like to talk a little bit about, you and how you and I met. I mean, we know how we met, and then your course, because you've just been so impressive in the group.
Well, you've done the beta testing for me as well, and I was glad for that. But yeah, the course idea and the reason I joined the little community that we're part of now is sort of like podcasting, and then wanting to share knowledge. So I've been podcasting like yourself. I mean, how many years have you been podcasting, Betty?
About 2.5, but I've been slacking lately for sure. No question.
Well, yeah, same here, 2 years.
Yeah. I've had a little bit of issue with direction. I want to go, but where I'm going now is to follow people's journey who just bought or sold a practice. I was focusing, we talked about this a little bit before I think we turned on the recorder, is like I was focusing a little bit more on money, which I still think is really, really important topic. But I was getting hit up and having people record that were just, what should I say? Charlatans, just trying to have access to dentists, most of whom were financial planners. And just do anything to talk to groups of professionals. And I ended up not liking that direction. So I went back into, what I do for a living, which is sell practices and try to follow people's journeys and help other people that way. What were the pitfalls and that kind of thing. So yeah, I veered a little more into money because that is a passion of mine, but I've kind of gone back to the practice sell kind of thing.
Good for you, and well done for sort of taking that step and moving away from what you weren't enjoying, and going into more of what you like and what you produce and what your listeners will value more, I guess.
I just didn't feel good about talking to people and putting them on my podcast that I was not comfortable with them philosophically at all. And some of the podcasts that came across when I would question them on, oh yeah, borrow money from your house and put it in your retirement plan so you make more money, the financial planner. I was just not on the same page with a lot of people. And that did come across. So that's not the direction I want to go, to use my platform to do that kind of thing. But you, on the other hand, did an online class for dentists. So tell me a little bit about that journey, how you got interested in, the splint topic and what you did.
Sure. So, I mean, like I said, 2 years ago, I started the podcast almost by accident, because what I was doing at that point was I'd moved back from Singapore, where I was practicing and really loving life. Singapore's such a beautiful place. Have you ever been, Betty?
No.
Oh, just like Asia light, just the most beautiful weather all year round, great food, great culture. And we had a great time, me and my wife. But my wife got homesick, so we came back to England. And now word got out because morale in the UK dentistry scene is not very high. Okay, it's low. So word got out that, hey, there's this dentist who went to Singapore and he came back, and maybe we should start moving out to Singapore. So like every day on my commute home, I was on the phone to a brand new dentist. They were asking me questions. Oh, what's it like in Singapore? How much do you earn? Do I need to do any additional degrees? Are there any exams? The whole, the whole spiel. And every day I was speaking to new dentists. So eventually I was like, okay, let me record an episode on a pod. Let me start a podcast. And then the first episode was about, being a dentist in Singapore and my experiences, just so that I could free up more time and I wanted to help everyone, but I wanted to free up my time because I was doing one-to-one. I just couldn't handle it, right? So I did one-to-many, and that was my first foray into podcasting. And then I started to come out of my shell because I'm quite a geeky dentist. I do.
And you're really shy. You're so shy.
Exactly. So that to allow me to practice my excess energy and place my excess energy somewhere, the podcast became my channel for my energy. And I started to bring on, like, for selfish reasons, I started to bring on guests who I want to learn for. And at the same time, I was learning, but then people were learning. And it's grown and grown and grown. Like, recently about 150,000 listeners plus, and something that, 120 countries in the world. And it's just amazing. But one thing I found around that middle of podcasting was I was just doing some solo episodes about one topic I'm very passionate about, which is occlusal appliances and splints. And that absolutely blew up. Like, there's one episode called Michigan Splints Are Overrated. And people really, really took an interest in that. And then I just started to share, like, dentists were now calling me up and asking me for advice about which occlusal appliance to make for their patient. And this is something that I've been attending courses like for so long to learn from different people and to develop and fine tune my own occlusal philosophy. And then I thought, okay, that's it. I have to share this content. I have to share this knowledge. So I put together like 11 plus hour modular learning. And by the way, along the years, I've done a certificate in dental education because I love sharing what I know and trying to become the best educator I can be. So that was the birth of that. And part of learning about how to become a better online educator, that's how I met you, because it was part of that community that we joined. And that's how, I guess, it led to this moment now where we're discussing all these interesting things and two podcasters have connected.
Yeah, very cool. So what made you interested in splints? Where did that come from?
Confusion. Like, I find like I'm such a geeky dentist that if something confuses me, like the two things that confused me the most at dental school was orthodontics. Like, what the hell's going on, right? Like, how is this working? This is a voodoo magic. And then the other one was, occlusion, always, right? Like, most dentists come out thinking, what the hell? Occlusion is a very complex field. There's too many schools of thoughts. So fast forward now 8 years, and the two things which I ended up doing extra qualifications and extra learning on is lots of occlusion courses. Like, a lot, flying all over the world, and orthodontics. I've got a diploma in orthodontics. So my personality couldn't stand being confused. So I ended up just pursuing more and more in that. And then so that really piqued my interest, learning from different educators, Michael Melkers, Barry Glassman. I did the Dawson Academy. My principal is Pankey trained. So all these different schools of thoughts, and just trying to figure out why and how and what are these different schools of thought. So that's what I really got into. And also, I'm a massive bruxist myself. So helping my own self and making my muscles relaxed also sort of sparked me on to help other patients and then dentists.
So what's your philosophy with splints? I watched part of your class. Obviously, I could, but I'm not so interested in watching all those hours of dental anymore. But the class was fabulous. You were dynamic. It was fabulous. But what would you say your philosophy is? Is it more like Dawson? Is it more like Spear? Is it more like...
That's a great question, Betsy. I think my philosophy is an amalgamation of all those, but very much it is diagnosis led. And there's another episode I had on my podcast, which is the best splint, and the whole episode I was leading my listeners on. I was like, yeah, there's something called the G splint, the Golati splint, right? And this is like the best splint ever. And I was just like building it up. But really, the moral of the story was, every patient's G-splint is different, right? Because it's like depends on, have they had orthodontics before? Are they having pain, or is it just protection? What's the goal? So the philosophy is very much getting a good history, getting a good diagnosis, and also looking at the patient's like features. What are they likely to comply with? What are they likely not to comply with? Because Betty, one thing we can't rely on when it comes to occlusal appliances and splints is the evidence base. Like, the literature is absolutely poor and unreliable. So therefore, we have to use the other two arms of evidence-based dentistry, which is the patient's values and clinician experience. So I've been taught by such great people in occlusion, and I've adapted it and sort of taken a leaf from Pankey, taken a big leaf from Dawson, the whole B-splint stuff, learned a lot from the NTI guys, Barry Glassman, and I've made my own school, which is very much led by diagnosis, but that no one's right or no one's wrong. But what does this camp say? What can we learn from that? What does this camp say? And sometimes it's arts and crafts, right? No, every patient's different, every patient's unique, and you have to find that magic potion that will work with your patient.
I think that's a really good philosophy, because there are so many different camps. And I agree with you. When I was practicing, I did Pankey and Spear and Coyce, and I was just confused. I mean, totally, completely confused. Like, what's the right way to go? And I never put it together. I just quit. So
well, why did you? I never got to ask you why. What made you make that big life decision and leave clinical dentistry?
Oh, that's a long story, and it's multifaceted. I mean, I think that one of the main reasons is, well, let's see. First of all, I got divorced, and I had 2 little kids, and I thought, I don't like anything about my life, so I'm going to redo everything. And also, I think I wasn't truly a dentist. Where you're excited about it, all that. I love talking to people. I love diagnosing. I love doing the treatment plan and selling the treatment plan. And it's like, oh my God, I have to do the work now. So I didn't like being chained down, where I could say, okay, February 2022, this is what I'm doing on who. And then the Rancho Cucamonga built a courthouse right behind my office, and I started getting a lot of attorneys and judges. I had lots of attorneys and judges as patients, and I just thought they had a lot more fun in life than I did.
Wow. The grass is always greener on the other side.
It is always greener on the other side, but I just really feel like I wasn't a dentist at heart, and I think I was a mediocre dentist, and I was doing all these great classes, but I thought, I don't think I can really perform and, do it at the level that is needed. I
wonder how many hundreds of dentists, based on this last 2 minutes of this episode, will now reconsider their careers.
Probably none, but they should. I was in, I don't know if you've heard of, what's the name of it? It's Carl Reeder's group, and that went on for many, many years, 40 years in Newport Beach. Newport,
not familiar.
Some kind of study club, and it probably had several hundred members, and I was a member. And, everyone knew I was doing this. I had 50 people pull me aside and say, I wish I could do what you're doing. And then I had probably another 50 say, you're making the biggest mistake of your life. And one person, I said, if I have to flip hamburgers at McDonald's, I'm going to be happier than what I'm doing now. So I'm doing it. And I didn't have a lot of things tying me down, like, a spouse and debt and this kind of thing. So, the risk was all mine.
And how do you feel now? And how do you feel now? Like, are you glad?
So glad.
Amazing.
I did it. Yeah.
Good for you.
Because I just wasn't, I went into dentistry. I was on the cattle train with all my friends going into medicine, dentistry, etc. But I really never made the choice that that's like what I want to do. And now that I sell practices, I would say 80% of the dentists are kind of mentally in my camp, whereas 20% are like you. They're like, love dentistry, every little bit of it. But a lot of people do not. I mean, it's not unusual. Even if they're good dentists, they don't like it.
I agree. And I think that 80-20, I agree with it. It's a figure I agree with. I think 20% are overly passionate. And then 80% are just like, you know what, it pays the bills. It's okay. I can tolerate it. And then some of those 80% are like, you know what, I'm living, my life is fake. Like I'm hating this. And you made that decision that, you know what, this is not for me. And kudos to you for doing that. That takes a lot of guts. So well done. And look what you made of it. You know, I love what you're doing and what you've done and helped so many people in a different way.
Yeah. I mean, totally different path, but I loved it. I made the decision early on after I graduated from law school to stay in dentistry because all my friends were dentists. Everything I knew in my whole world was related to dentistry. So I made the decision to stay in that space. So yeah, it's been absolutely great. And I'm very happy. I don't think I'd be happy if I'd stayed a dentist. So, but I think you're doing the right thing. If you're not happy in dentistry, I think you need to look around for things that could make you happy by doing different procedures and staying engaged and interested and figuring out what parts you do like and focusing your practice on that. Because I think, there's a whole bunch of middle ground between doing what you're doing and me quitting. And most people are in that middle ground.
You're so right. And I think that one advice I can give to anyone listening now, and then they've heard you say that how grateful you are that you made that decision to leave dentistry. And here I am on the opposite end of the spectrum saying, oh my God, I love dentistry. I guess if you're stuck, if you're unsure, then I think totally do what you suggested there is that dentistry is such a flexible field. Like you can literally limit your practice to a couple of procedures. You can find your niche. A lot of other professions, you can't do that. So it's about finding your niche in a way. And sometimes it means that you have to get out of your comfort zone to experience a new course or a new philosophy. And there are many, as much as people hate it, there are lots of different schools of thoughts. And sometimes you just need to hear another school of thought. It's like a religion almost, right? It's like a cult. You have to almost join another cult and then they might rekindle your passion for dentistry. And that's one of the reasons why I love the podcast I do, because obviously your podcast, Dentistry Rising, has a different angle. Mine is very much trying to attract all these dental geeks. And so I love getting messages from all over the world saying, I actually lost my love for dentistry. And now from listening to your energy, I've regained my love for dentistry. And that's the biggest praise I've had in my life. So I think that's what it's all about for me.
Yeah, that's really, really a gift. That if you can find that. And one thing, just to talk about my money passion a little bit, one thing that holds dentists back from being able to do that is having too much debt, and not continuing to have the freedom to do what they want to do.
Is this debt from dental school? I
would say not dental school. I mean, dental school is useful debt in most cases. But when they go out and they have to have the new Mercedes, the new BMW, the multi-million-dollar house, and, we're payment by payment. And then you have a hiccup and, you're in trouble and you can't make other decisions. You can't say, okay, I think I'm going to just chuck it all and move to Michigan or wherever, I mean, I think you really limit your life choices when you get in so much debt. And here where I live in Orange County, I mean, it's very prevalent where you have to keep up with the Joneses by having the new Tesla, the new whatever. And that's a huge mistake dentists make, I think. And it really limits their life choices.
Yeah, I mean, maybe it's because I'm an associate and I haven't taken on huge debt because I haven't even looked at buying a practice. So maybe I'm not speaking for the rest of our profession. But in the UK, it's not something we discuss a lot about, debt. And I feel as though US grads, they do talk a lot about debt, and debt is like quite a significant thing there. So that's another difference there between UK and US. That you guys are always, I had lots of dentist friends in Singapore who trained from the US and they moved to Singapore, and then they were talking about huge debt and stuff, and it's not something that you have here. And I think maybe it's because one of the good things, I guess, is that you wouldn't believe how much I paid for my dental degree, right? My tuition fee at the time, I mean now it's a bit more, but at the time was £3,000. Let's call it $5,000 per year. And that's the tuition. So yes, I pay for my rent and stuff separately, but that's nothing compared to what you guys pay.
Oh, it's very common for people to come out with $400,000 to $500,000 worth of debt. Very common.
See, that's why I thought you guys, predominantly the debt was that. But I guess you guys are just accumulating that debt more and more.
Yeah, I mean, I think, you come out with $500,000 worth of debt, and then lenders will give you more money, and because you're a doctor, and you pile on top of that your Tesla payment, your Mercedes payment, your boat payment, your this, your that. And I think the dentists feel they have so much debt that it doesn't matter. I've told this story before, but it still made one of the biggest impressions that on a money scale that I've ever had. I was speaking for the CDA at some California Dental Association with some new graduate kind of thing. And right in front of me, this girl sitting had this beautiful Louis Vuitton purse. And I had just looked at that purse at the mall, like a few days ago, and it was like $11,000, $12,000. And I thought I would never pay that much for a purse. But I'm thinking in my head while I'm talking, I wonder if it's a fake. I have all this internal dialogue going about her purse, and which is ridiculous that I'm talking, on and on. And then she gets in line to talk to me afterwards. And I had to ask her, I said, is that a real Louis Vuitton? She goes, oh, yes. How much student loans do you have? She goes, 500,000. I'm like, what are you thinking? And she said keywords to me. It's like monopoly money. She goes, I can never pay it off. It's not even real. I don't know. I buy what I want.
That's it.
I mean, that's a very, very common feeling or response that new dentists have because they don't understand what it takes to pay off $500,000 of loans. I mean, they kind of get it, but it's like a forever jail sentence, and they're just not going to live that way.
I can't even imagine that level of debt, and that's it. That's another major difference between UK and US is that maybe that's why you guys are borrowing more money, because you already have such a huge level of debts. What's another extra couple of 100,000 here and there, right?
They just don't feel it. They just don't understand it. They don't feel it, and they think, I'm going to be in the grave before I can pay it off, so I might as well enjoy life.
Do you know if most dentists actually do eventually pay it off?
Some people do. I mean, some people really focus on getting it paid off, but that's a minority. And then you're really trapped. I mean, you are trapped in that practice, and you better produce whatever it takes. Because then you take on a wife and kids, and they all have expectations too. So we get ourselves in a lot of money situations with dentists in dentistry here, which it sounds like you don't have. So that's a good thing.
Mm-hmm. No, we don't. And you reminded me of something actually very interesting, is another cultural difference. I mean, dental cultural difference is that we have this perception of American dentists that you guys are, no offense, you guys are really aggressive, like treatment planners. That you guys are like, you got like two hand pieces with these big fat burrs, and you're ready to just cut crowns and everything. Something that we think needs a Fisher seal, and you guys are like, right, let's crown it. And I experienced this firsthand. Like, N equals one. Like, there's one dentist who qualified in the US who worked in the same practice as me in Singapore, and where I was doing all these composites and stuff, being minimal, every patient got a crown with her. So I don't know, that's this perception that we have that you guys are very aggressive treatment planners.
I think that can be true with a lot of people. That can be true. And of course, then it comes down to an individual's own ethics and morals and beliefs and that kind of thing. For myself, when I first got out of dental school, I had a job. It was really hard to find a job. So I finally got a job, and probably my first couple weeks or so, they made me do 2 apical retrofills on 6 and 11. And I did it. I mean, to this day, I'm embarrassed and ashamed, etc. I did it. And I had no idea how to do it. I've never done it.
Yeah.
I mean, I knew in theory what should be done. And I swear to God, that person lost 6 and 11 because of me. But it's not, I mean, people do stuff like that. I did it. So I didn't lose my job, and so I wasn't embarrassed that I couldn't do it, but I'm way more embarrassed that I did do it. I'm just horrified that I did it. But it's not, it's just not uncommon for whatever reason. You got to make the payment. You can't lose the job, whatever. People are compromising. So I think it does come down to your individual ethics, who you are as a person, how you diagnose.
Well said. So Betsy, one thing I haven't told you yet is that in every episode that I do, I have a protrusive dental pearl. It's like one tip I give, like, clinical dentistry or communication or whatever. And one of them I just stole from your podcast. Okay. So I need to now credit you, because you did such a good job of reminding me of this. It's such a great little pearl. I'm going to let you say it because you'll do a much better job. But it's basically the one about the power of a silence after you present a fee. Can you just give my listeners again a flavor that only Betty can of that?
Well, I do think being quiet and, after you present a fee, being quiet is hugely important. I think it's really important to present the fee in a confident and clear manner and not too confusing, and then be quiet and let a patient respond. It's kind of the old philosophy of he who speaks first loses. But when you know that you're doing whatever it is, say you're doing 6 anterior veneers, the fee will be $12,000. That's it. Be quiet, keep eye contact, and they're either going to say something that lets you go the next direction. Sure, could you do it next week in time for my daughter's wedding? Or, that's nothing I can afford, but I'll save for it. Maybe we can do it in a couple of years. Whatever it is, I think the doctor is always best positioned to handle that objection or the next comment compared to an office person. I don't like doctors to delegate, treatment presentations, at least of any magnitude, to an office person because they can't, they'll start talking about payments. They'll start talking and payments may not be the issue. So I think the less you say when you're presenting the treatment, the better. You don't want to confuse people. You just want to be really clear, then be quiet and listen to what they say and go from there. So I don't even remember what I said on that podcast,
But no, you covered it well there. But it's an important lesson. I shared it with my listeners as a pearl, and I really do think that a lot of young dentists, it can be a challenge, right? Or any dentist, it can be a challenge. Like when you're not used to presenting fees and you're doing more complex work, and to maintain that eye contact and say it confidently for the first few times, and then you have that silent, and those 3 seconds seem like 3 minutes. And then what's the most common thing we'd say? Be like, oh, why don't you think about it? Or why don't you go home? And that's the worst thing you could say.
Like, get out of here. I'm uncomfortable.
Yes, exactly. So I just want to highlight that.
I did use a lot of consultants in my dental practice, and like you say, I took little bits from each of them. And even when I present listing agreements now, I do that. Like, this is how much it is. This is what I'll do, won't do, whatever. They do it, they don't do it. The same thing with presenting treatment. I think you need to be eye level with the patient, knee to knee. I think you need to be looking at them, not have the chart, not have a lot of extraneous hand movements. Just say whatever it is. You have the veneers, the cost. You don't have to talk about everything else in the world. You can talk about that later. Like after they've accepted, we're going to need to take models. We're going to need to da-da-da. But to present the treatment, confidence, clarity, and keep it short and be quiet.
Perfect. And I love it. And I just wanted to highlight again, in case you missed it the first time on my show, what an important tip that was. Any other tips that you have? I know I'm putting you on the spot here, but any other, like one more tip you can give maybe to the dentist listening from the Protrusive Dental Podcast side to help become better communicators when it comes to money or treatment plan presentation? Any other tips that you picked up when you were getting these consultations?
Let's see. What could I say is another tip? I would, there's a lot of dentists whose practice I go into and have no idea about their overhead. And, of course, that's a lot more important when you own your practice, or it's very important when you own your practice compared to being an associate. But I think you need to stay plugged into your practice as to what the front desk is doing, what your numbers are, how much you're diagnosing, how much... sometimes people say, well, there's no crowns on my schedule. Well, that's because you didn't diagnose anything. One of the consultants I had first, I had like a 2 and a 4-year-old. I had arrived late. I'm paying this consultant through the nose, and here I come in 20 minutes late. And she just kind of totally slowed me down. She said, do you know that the energy that you bring into the practice today has a huge effect on how you're going to diagnose, how the patients are going to feel about you, everything. So you need to calm it down, get there here a half an hour early, and have your head in the game. If you only want to work 4 hours, that's fine, but for 4 hours, you have your head in the game. And I think that's a huge mistake dentists make, is they come in very scrambled, not ready to work, and not ready to be totally present in their practice while they're there. I'd like people to cut hours and be totally present and probably do double the production.
Well said about presence. And to add on to that, like, forget about any arguments you had with your spouse. Forget about what you had for dinner last night. Forget about all the unread emails. You have to forget about absolutely everything and give your patient every single ounce of your energy.
Yeah, and then you will diagnose what you want to do. Patients will like you and come back and do the rest of their treatment because they feel that you're totally present. I mean, that's what we all want from all relationships we have, with healthcare providers, with friends, with everybody. Like, be totally present, be with me, and then when you're not with me, do what you want.
100%. And that's when you get to be yourself and show your true self and practice with your values at display. And then you obviously in time will attract the patients who have the same values as you. So it goes full circle, basically.
Right. I think it does too. It really does. And the people that do the huge numbers, that's what they're doing. They have their life together or organized in a way that they can be calm, they can be clear, they're confident and focused, and it comes out in all aspects of their life.
How many days does the average dentist clinically work in the US?
4.
4, okay.
I think 4. How about there?
Yeah, I mean, maybe 4, maybe even 4.5, 5. It really varies. I think if you're a practice owner, you can, maybe work 3. It varies, but there's a whole saying that if you drop back to 3.5 days clinical, I think maybe Pankey sort of said this, but if you drop back to 3.5 days clinical, you'll find that your income really doesn't drop that much, but your productivity, your energy levels remain high. So the reason I want to just plug that in there is because we can burn out if you do too many clinical hours, and to be able to show up in the way that we described in the last few minutes, you have to almost do less and go in less and work less hours so you can have the energy to be the best dentist you can be.
Yeah, I'm totally a fan of that. 3 days, I think. I mean, dentistry is hard work in every way, not only physically, but mentally, emotionally. 3.5 days, I think, is really perfect. And, do a lot of CE and interact with your colleagues and, enjoy a long career, not trying to burn out in 5 days. I mean, 5 days will burn you out really quick.
Obviously, if you're the new grad, then there's the whole beauty, because, to balance that out with accumulating your 10,000 hours, right? Getting those failures in. So there's something to be said about actually going quite hard initially, but not at the sake of your mental health. So there's a fine balance to be struck initially, but as you gain more experience, definitely, make time for the finer things in life and drop back your clinical hours so you can have more energy and vitality.
I agree.
Amazing. Well, Bette, it's been great to have you for the Protrusive to listen to, and I hope this has been valuable for your guests as well.
I'm sure it will be, and I think everybody will be really interested in hearing it and hearing what dentistry is like in England and checking out your course.
Thank you so much.
Thank you.
So thank you so much for listening all the way to the end, guys. That was Dr. Bette Robin from the Dentistry Rising Podcast. Please do check it out if you like Betty's style. She is very much like her episodes are non-clinical. So I think there's something beautiful about that as well. And you have to respect her journey and her sort of desire to make massive change in her life and leave dentistry. So that has to be respected. And I think it's great what she's achieved as an attorney and also now looking at practice acquisitions. So I'll catch you in the next episode, same time, same place.